So, good evening, colleagues. What I am presenting today to you is a rare case of a myoepithelial sarcoma in a pediatric patient and the challenges that we faced in managing this case and how we overcome them. So, the patient was a 2-year-old boy who had essentially had a mass in his mouth which had been growing for the past 1 year. When he came to us, 80% of his mouth and throat was occupied by this large tumor, which we biopsied and was a myoepithelial sarcoma. The PET scan showed disease localized in the masticatory space. So that is the space where all our muscles are between the upper and lower jaws. And it was extending all the way up to his skull base and of course growing into his mouth. And there were a couple of challenges that we faced with this child because since he'd had a tumor for a year in his mouth, completely blocking it, this child had not eaten. So he was highly cachectic and very underweight. Inactive, 2 years old, but not walking. The tumor was very large in the masticator space into the mouth, involving the maxilla and going all the way up to the base of the skull. The third ideal treatment is surgery, but we are anticipating a very long operation and we were unsure if we can resect this tumor completely. And with sarcomas, the challenge is to resect with negative surgical margins, otherwise cure is very unlikely. And the last challenge we faced was how would we reconstruct the defect in his mouth once we had finished the operation or the resection. So initially we consulted all our colleagues, we had a tumor board, and the pediatric oncologist suggested we could try sirolimus, which is a targeted therapy and sometimes may shrink these tumors. So we gave him sirolimus and pleasantly he had a very dramatic response to the drug and his tumor shrunk on the outside at least by about 50%. So his oral cavity opened up, he started taking a little bit by mouth, and we now felt we can remove the tumor with negative surgical margins. So we took him to surgery. It was a combined operation with us, which is head and neck surgery, pediatric surgery, and the plastic surgeons for reconstruction. At operation, we removed the left half of his cheek, his jawbone, lower side, the maxilla, and all the muscles of mastication, along with what we call the infratemporal fossa, clearing the tumor off the base of the skull. We then repaired the defect in the mouth using a microvascular free flap, which is also very unusual to do in a 2-year-old child because in microvascular, basically you harvest tissue and then you harvest it with the artery and the vein attached to it, and you reattach the artery and veins to vessels in the neck so that the blood supply can be re-established and the flap survives. So in a 2-year-old child, these are very small vessels. You have to work under very high magnification under a microscope and somehow re-establish the blood supply so the flap that we put survived. In this child, we took a flap from the thigh. It's called an anterolateral thigh, so skin of the thigh, which was used to fill up the defect which had created in the mouth of the child. The entire operation lasted around 12 hours and we were greatly helped by care in the pediatric ICU because you can understand, again, a small child, 12-hour surgery, cachectic to start with, and now we'll have sequelae of surgery where it's difficult to swallow for the first few days, etc. Post-op course was complicated by a bit of fever, and it was presumed in a child like this we're probably dealing with mild sepsis, but fortunately with intravenous antibiotics he came out of it. By around the 7th day, he was out of the ICU. Gradually, we were able to start him with oral feeds, and on 2 weeks, he finally left the hospital eating well by mouth. Post-op, he was with us for about a month and a half. His pathology report showed the expected myoepithelial sarcoma. All our surgical margins were negative, and we decided this child needs no further adjuvant therapy. During follow-up in the outpatient for about 6 weeks, we saw wonderful improvement. The child gained almost 2 kilos in about 2 months because he just not eaten, so his body was very hungry. He rebounded wonderfully. He started walking and even running around, and that was quite a pleasure to see. We have this child on follow-up. These tumors can recur, So we're going to review him periodically. But given that we were able to resect it completely, we think we have a good chance we may cure this child. I think at least for our initial treatment, our success in effectively managing came down to multidisciplinary care. We had the pediatric oncologist chip in with the suggestion of using sirolimus, which shrunk the tumor, made it operable, and got us to the point where we could consider surgery. And then a combined operation between pediatric surgery and us, because we as a service are not comfortable looking after 2-year-old children who are cachectic. So pediatric surgery came in with their inputs. They actually performed a gastrostomy at surgery, anticipating he needs long-term enteral feeding. So their inputs and care. Plastic surgery in performing the microvascular in a 2-year-old child. Maybe not the first ever done, but definitely a very, very rare event. And then excellent care in the pediatric ICU to bring this child out from a 12-hour operation through post-op sepsis to leave the hospital on his 2 feet in 2 weeks. So I think we were fortunate in that we had great coordination, things fell into place, and all the team members chipped in and I guess helped this child through his recovery.